moving on to discuss pneumonia. The hallmark, the defining situation with pneumonia is that you have infection of the alveoli, and that causes consolidation. So that is where the air that's in the alveoli has been replaced by an inflammatory exudate, bacteria, white blood cells, and red cells, replacing the air. And you can see that on the chest x-ray. So for example, this chest x-ray shows somebody with a right upper lobe pneumonia, and there's a white patch over the right hand of the lung, and that reflects the dense consolidation that's occurring in that area, and there's no air left in those alveoli. And this distribution of pneumonia is a lobar pneumonia. It's affecting one lobe only, and the rest of the lungs are clear. And that's the commonest presentation of an acute pneumonia. You can get pneumonia which is patchy throughout both lungs. So little patches throughout both lungs. And that's called bronchopneumonia, and this is an example of that. This is a much more serious disease in general, because that's a very extensive infection and is often a fatal event in patients with underlying severe disease such as a cancer or another disability such as dementia or a chronic neurological deficit of some description. A third pattern of pneumonia that we can see is an interstitial pneumonia. Now, you probably can't tell very easily on this chest x-ray that it's abnormal, but there is a widespread reticular nodular infiltrate in both lungs, but it's very subtle. And that represents, again, a diffuse pneumonia and is commonly associated with the atypical organisms that I mentioned earlier, Mycoplasma and Chlamydia. The overall importance here is that if you have pneumonia, there is some form of alveolar consolidation, usually lobar, but potentially interstitial or bronchopneumonia as well. And we can detect that clinically. So if you have somebody with pneumonia, the area of infected lung, the area of consolidation, will be dull to percussion, and when you listen to it, there will be crackles in that area and potentially bronchial breathing. And the chest x-ray, as we've seen, is obviously abnormal. It shows airspace shadowing with white patches in the affected area, and occasionally what we call air bronchograms. That's where the bronchus that's moving through the consolidated lung has been delineated by the alveolar consolidation either side of it. So it shows up as a black tube going through a consolidated area. So pneumonia is classified into different types. And the first and the most important, and the subject of most of this talk today, is community-acquired pneumonia. And that is what it says in its name. It's a pneumonia that is acquired when you're living at home and not in hospital or anything else. So it's the normal standard pneumonia that you pick up in your everyday life. There's a subcategory of community-acquired pneumonia called healthcare-associated pneumonia, which has been defined recently in America, but probably is not relevant in Europe. And I'm not going to discuss that in any more detail today. That is a pneumonia that occurs in people who are in long-term care facilities, nursing homes, etc. But in fact, in Europe, it's probably not that much different to normal community-acquired pneumonia. And therefore, we group it with community-acquired pneumonia. The other important forms of pneumonia are hospital-acquired, which, as it says, is a pneumonia that you develop when you're in hospital. So you're admitted to hospital for another reason, say you're having an operation, and then after the operation you develop a pneumonia. That would be a hospital-acquired pneumonia. It's also those patients who've been in hospital recently and then come back in with a pneumonia, because the organisms that are causing that pneumonia have probably been acquired whilst they were in hospital previously. They are also defined as hospital-acquired pneumonia. A third form of pneumonia is ventilator-acquired. That's basically a subtype of hospital-acquired pneumonia, but it means that this is pneumonia in patients who are on the intensive care unit being ventilated with an endotracheal tube inserted. And they are susceptible to pneumonia because the ET tube, the endotracheal tube, bypasses quite a lot of the normal immune mechanisms for preventing infection. And the last category is immunocompromised host. These are patients who have a very severe defect of their immune system, and that allows a range of unusual organisms, bacteria, viruses, and fungi to cause the pneumonia. So the chance of having a pneumonia to an unusual organism is much higher in these patients. But we're talking about patients who have severe immunocompromised state. So those who've had chemotherapy for cancer, those with HIV infection with poor CD4 counts, those who had transplantation of their marrow or of a kidney or their lung, etc. So patients really with very severe immune defects. So, who gets pneumonia? Well, there's an easy answer to that question, and that is absolutely everybody could get pneumonia. It's not uncommon in young people, but it is particularly common in two age groups. The very young, the under fives, and as I mentioned before, it's the commonest cause of death across the developing world in the under fives, and the elderly. And there's an almost exponential increase in the chance of developing pneumonia after the age of 65. So it ends up that the chance of developing pneumonia in somebody who's very old, over 85, is about 5% a year. The risk factors for pneumonia also, as well as age, include previous influenza or other viral infections, because, as I mentioned in the influenza lecture, a viral infection of the respiratory tract affects the immune response to bacteria and allows bacterial infection to develop as a consequence of the viral infection. So secondary bacterial pneumonias after influenza are very common, and that's the major way by which death is caused during the pandemics, or has been in the past. For example, the post-World War I pandemic, which killed 20 million people. Most people died of pneumococcal and staphylococcus pneumonia after having the influenza virus infection. Other people who are more susceptible to pneumonia are alcoholics, or people with liver cirrhosis, because that affects the ability of the immune system to fight bacteria. Smokers, that allows the bacteria to establish infection in the lungs more readily. Actually, having had one episode of pneumonia makes you 2 or 3 times more likely to have another episode. It marks you out as somebody susceptible to pneumonia. And then patients with chronic disease, chronic lung disease, COPD, for example, chronic neurological disease, dementia, previous stroke, etc., any renal impairment or cardiac failure. These are all reasons why these all increase the chance of getting community-acquired pneumonia. Now, if you have hospital-acquired pneumonia, you need to be in hospital. So if you're hospitalized for a reason, then you're at risk of hospital-acquired pneumonia. And if you're ventilated, then you're at risk of ventilator-acquired pneumonia. And the risk of that is about 1% per day that you are ventilated. And then, of course, the patients who have immunosuppressed for their treatment of their cancer or because they've had a lung transplantation, etc., those will be at risk of pneumonia of the immunosuppressed patient. What are the symptoms of pneumonia? Well, actually, they're very straightforward. You have the systemic symptoms that you get with infection: fever, feeling unwell, occasionally you get the shakes, the rigors, and you're not eating, and you feel terrible, and you want to go to bed. Then there are the focal symptoms you get because it's a lung infection, and that will be cough, producing a purulent sputum sometimes. Sometimes you get blood in that as well, and the mixture of purulent sputum with blood becomes what we call rusty sputum, a sort of browny colour sputum. You may get pleuritic chest pain if the pneumonia is causing overlying pleuritic inflammation. That's called pleurisy. And because the pneumonia consolidation is affecting the ability of gas exchange in your lung, then you might be breathless as well. When you look at the patient and examine them, again, you have the general examination findings of somebody with an acute infection, pyrexia, they don't look very well, they may have they should have a tachycardia, and they have an increased respiratory rate because of the problem with the consolidation. There are a few other issues. They may have herpes labialis, so herpes simplex infection around the mouth actually often reactivates during people with pneumonia. And if they have significant hypoxia, then they'll have central cyanosis. And pneumonia is a relatively common cause of acute septic shock, so they might have hypertension as well. And occasionally patients have atrial fibrillation because acute lung infections are one cause of temporary atrial fibrillation. So that's the general examination. When you listen to the lung, we've already mentioned the signs, which essentially is focal asymmetrical crackles, crepitations over the areas of consolidation. If it's really dense consolidation, it'll be dull to percussion, and there'll be bronchial breathing as well. And about a third of patients with pneumonia will have a small effusion, and some of those will have a pleural rub. So if somebody presents with pleuritic chest pain because of the pneumonia, the pleurisy, it's quite likely that there'll be a pleural rub over the area where they feel the pain. Now, if you're trying to work out whether somebody has a pneumonia or an acute tracheobronchitis, and this is a very important distinguishing situation because tracheobronchitis is a relatively benign disease and will settle, whereas pneumonia does have the potential chance of becoming a very severe disease. Then there are a few of these signs which are important. So for example, you will not get crackles if somebody has a tracheobronchitis. And so the focal lung signs that you get in pneumonia are not present if somebody has a bronchitis. In the general examination, if you have an acute tracheobronchitis, it doesn't cause impairment of respiratory function to a significant degree unless you have an underlying lung disease. And so in the normal patient, there shouldn't be an increased respiratory rate. They should not get cyanosis. And it should never get severe enough to cause hypertension or a particularly high pulse rate. So what are the principles of management of somebody who's presenting with what seems to be a community-acquired pneumonia? Well, first of all, you need to confirm the diagnosis. Then you need to assess the severity, and then you need to think about treatment. And that has three main components to it. Correct the oxygenation, because that's the risk for mortality. Treat the fluid balance. Again, hypotension is a risk for the patient. And three, clearly, it's an infection, and you need to kill the pathogen, and that's going to require antibiotics. And then you need to monitor to make sure that the patient's improving with whatever management you've instigated. So to take these in turn, confirming the diagnosis, essentially that's a chest x-ray. You think the patient has some crackles over the right lung and they're presenting with a fever, then you need to know whether there's consolidation present. So do a chest x-ray and it might show lobar consolidation as is shown here in the right lower lobe in this chest x-ray. It's also very important to do a chest x-ray to look for complications, and we'll discuss some of those later in this talk, but we're talking largely about pleural effusion. And there may be related pathologies. So for example, if you have a lung tumour which is blocking a bronchus, then you'll get pneumonia distal to that obstruction quite easily. So a chest x-ray might help identify patients who have coexistent pathology which is relevant, such as a lung cancer. And also, it will help confirm that there isn't another diagnosis present and that you've been fooled and this is not your pneumonia. For example, pulmonary edema, etc. Sometimes you might need to do more extensive radiological investigations, such as a CT-thorax or a CT pulmonary angiogram, but that's unusual. And if you're really worried about heart disease, then you're going to need to do an ECG echocardiogram. Now, blood tests are quite useful in patients with pneumonia because there is a certain abnormalities that may show up. For example, if somebody's got an acute infection, you might expect the white cell count to go high, to be raised as an inflammatory response. That's true. It happens a lot in pneumonia, but also a low white cell count is also characteristic of infection in these patients as well. The urea and electrolytes can show significant abnormalities, commonly a raised urea and a raised creatinine due to a degree of acute kidney injury. And often patients have a low sodium as well, a hyponatremia. Liver function tests often are abnormal in patients with pneumonia, a high ALT and a high alkaline phosphatase, and the albumin is one of those markers of acute infection. So for example, somebody gets acute pneumococcal pneumonia, their albumin may drop from this normal range of about 40 down to 25 very quickly. So hypoalbuminemia is a marker of infection. Possibly the most important blood test is the C-reactive protein. This is a marker of inflammation. So if you have pneumonia, it's infection, there should be a very significant inflammatory response. So the C-reactive protein, which is normally less than 5, goes up very rapidly in most patients with pneumonia. So if you have a C-reactive protein which is not gone above 40, you might want to think about the diagnosis in a bit more detail because it may not be pneumonia. In fact, it's not uncommon for it to be above 100, 200, and even 500 or 600 in patients with acute pneumonia. The other blood tests we need to do are tests for oxygenation, which I'll discuss later, and there are some blood tests which are tests for potential infecting pathogens, which I'll also discuss later. So, what's the differential diagnosis of somebody presenting with what you might think is community-acquired pneumonia? Well, we actually mentioned already acute bronchitis, influenza bronchitis are two of the main differential diagnoses. The important thing there is they do not normally have evidence consolidation. If you have evidence consolidation either clinically or on X-ray, then that means the patient has a pneumonia rather than just a simple acute tracheobronchitis. Then there are a range of common non-infective respiratory diseases which really need to be considered of anybody presenting with an acute respiratory problem. Pulmonary emboli, pulmonary edema, acute respiratory distress syndrome, not that common but very important, and lung cancer. Now, the top two, pulmonary emboli, pulmonary edema, they're common causes of acute respiratory problems. And they're not infective, so that you should be able to distinguish in most patients pneumonia from those. But if you look at the data, many patients with pulmonary emboli are misdiagnosed as pneumonia initially. And the same for pulmonary edema. So that needs to be considered in differential diagnosis. Lung cancer, because of this ability to cause infection distal to where lung cancer may be obstructing the bronchus, needs to be thought about, especially in the patients who are over 50 who smoke. Just think there may be a lung cancer underlying this problem, or that the X-ray shadowing that you're seeing is not consolidation, but a large tumor instead. ARDS is the subject of another lecture. It presents with bilateral consolidation and marked hypoxia, and is actually a consequence of pneumonia frequently. It can also occur in situations where there is, without pneumonia, and that's a relatively common presentation of bilateral consolidation, which might be confused with pneumonia in some certain circumstances. In addition, there are a range of relatively unusual and rare lung conditions which cause inflammation and consolidation, or what looks like consolidation on an X-ray. And these, because they cause inflammation and systemic upset and have X-ray changes suggestive of consolidation, could easily be confused with pneumonia. Now, fortunately, they're very rare, but they do need to be considered in patients who are not improving. So these include diseases such as cryptogenic organizing pneumonia, a non-infective form of consolidation, pulmonary eosinophilia, and that's where you get eosinophil forming consolidation in the lungs, allergic bronchopulmonary aspergillosis, which is a subject of one of the airways talks, hypersensitivity pneumonitis, and vasculitis, which are discussed in the interstitial lung disease talks and the pulmonary vascular talks, respectively. So, for example, this is a patient, it's a 40-year-old man. He's had 2 weeks of fever and breathlessness, and a C-reactive protein shows there's quite active inflammation with a CRP of 222. Now, not unreasonably, he's been treated with antibiotics because it's thought that he may have an infection, a pneumonia, but he's not getting better. And in fact, it turns out that he has a disease, and you can see this here, which is causing an eosinophilic infiltration, a consolidation in both lungs, and as outlined by these the circles there. And this disease is called pulmonary eosinophilia, and the treatment that's required in these circumstances is corticosteroids. And with that, he gets better. So this is an unusual disease, but it's an example of what could be confused as community-acquired pneumonia. But I just have to reiterate, these are rare diseases, and they're only rarely considered in patients who are not getting better with antibiotics. Management, how do we assess the severity? And this is largely done using a score called the CURB-65 score. And this takes the 5 factors of confusion, whether it's present or not, a urea, whether it's greater than 7 or not, a respiratory rate, whether it's greater than 30 or not, blood pressure, whether the diastolic blood pressure is less than 60 or not, and whether the patient is over 65 years age or not. And that gives you a 6-point score, 0, 1, 2, 3, 4, or 5. And with that score, that defines how severe, or defines the mortality, the chance of death occurring with that episode of pneumonia. So, for example, if you have a score of 0 or 1, the chance of death is less than 1%, and that's very mild disease, and most of those patients can be treated at home. When you get to a score of 2, that's moderate community-acquired pneumonia, and most of these patients will need to come into hospital. You can see on this graph that the mortality of that's about 13-15%. It's quite significant. Then, as you go up the system, the mortality associated with the score becomes higher. So that with the higher scores, 4 and 5, the mortality is around 50%. And those are the patients with severe disease that you really need to consider referral to intensive care for close and aggressive management. As well as the CURB-65 score, there are other features that can be used, other clinical features that can be used to identify patients who may have more severe disease. So worrying features are those who are hypoxic despite having a high inspired oxygen concentration, patients who seem to have bilateral disease or disease that spreads during the hospital admission despite the antibiotics. If somebody has a blood culture which is positive for an infective organism, that instantly places them into a group that has a mortality of about 20%. The C-reactive protein, the blood marker for inflammation, if it's particularly high, above 250, that seems to suggest patients who have an increased mortality in some data that's been published. And then if you have a severe comorbidity, if you have underlying cardiac disease, underlying COPD, or renal impairment, then that is quite likely to decompensate because of the acute infection, and that will increase the risk of severe consequences of the infection. So just to go through a couple of examples, here's patient A, age 53, presents to casualty with feeling of cough and phlegm and fever for the past 3 days. He's not confused. Urea was actually slightly high, 9.8, but not terribly breathless. Blood pressure was normal. That gives a curve 65 score of 1, just for the urea alone. The rest were normal. So that's a 3% mortality. They're not hypoxic. Chest x-ray confirmed pneumonia, but actually they could be treated at home with some oral antibiotics. Patient B, on the other hand, 67 years of age, so he gets a point for that, is confused, gets a point for that because normally they're not confused. Urea of 10, that's greater than 7, so that gets a point for that, and is breathless. Respiratory rate's 30, gets a point for that. Doesn't have hypertension, so it doesn't get a point for that. Now it gives a curve 65 score of 4, and that suggests a mortality of about 42% for this sort of patient. In addition, I'm going with the respiratory rate being above 30, the PaO2 was low. It was less than 8, despite being on 60% oxygen, and there was bilateral consolidation. So this is a severe disease, markedly hypoxic. The patient needs to go to intensive care and probably needs to be intubated, or at least if there's not any easy, quick response to high flow oxygen, and they will need to be intubated and ventilated because of their marked hypoxia. And in this situation, that patient actually survived, although given the severity of the illness, it was touch and go. The other aspect of management is this correction of oxygenation. If you have consolidation, you are replacing air in the alveoli with inflammatory fluid. And that causes hypoxia because it generates what we call a right to left shunt. And what I mean by that is that blood coming up the pulmonary artery, which is deoxygenated, will reach the area with the consolidation in it, will go through that area, but because there's no air in the alveoli, that blood will not be oxygenated, and therefore it will reach the pulmonary veins in a deoxygenated state. And you end up mixing the deoxygenated blood coming from the consolidated lung with the oxygenated blood coming from the remaining normal lung. And the consequence of that is that you add mixture of hypoxic blood and normoxic blood, and the combination of the two will dictate how hypoxic the patient will be. So in this example, for example, we have a patient who has quite extensive consolidation, and therefore the deoxygenated blood shunting through that consolidated lung has a significant effect on the arterial oxygen concentration, reducing it down to about 80%. So oxygen needs to be corrected, and we do that using masks and, if necessary, mechanical ventilation. Another important physiological upset that occurs in patients with pneumonia is due to the sepsis, due to the septic shock potentially that can develop in a minority of patients with acute bacterial pneumonia. Before that, actually many patients, because they've been breathing fast, unable to drink and eat, they're dehydrated. So dehydration is common, and beyond that, some patients will develop septic shock with persisting hypotension even after they've been rehydrated. And acute kidney injury is very common in these patients as a consequence of these problems. So patients with pneumonia will require intravenous fluids to rehydrate them if they have got a low blood pressure or clinically they're dehydrated. And if the low blood pressure persists despite rehydration, then you need to consider inotropes and admission to intensive care to treat for septic shock and to avoid the downstream consequences of having hypotension, increasing kidney injury, etc., etc. Killing the pathogen. Well, when the patient first presents to you with pneumonia, you don't know what the bug is causing that pneumonia. So we treat the patients initially with what we call empirical antibiotics, ones which will cover the common causes of pneumonia. And so to do that, we need to know what the common microbial causes of pneumonia are. And for the industrialized world, these are relatively similar across different countries, and they split down into about 20-25% of cases are just due to viruses. influenza being the commonest one, but occasionally you get other viruses, rhinovirus, RSV, parainfluenza, etc., and adenovirus. And then 3/4 of the cases are due to bacteria. And those bacteria can be divided into two categories: the pyogenic bacteria, the ones that cause a high inflammatory response, focal consolidation, generally speaking, the ones that would cause more acute and severe disease, and that's mainly Streptococcus pneumoniae, which is responsible for about half of all cases of community-acquired pneumonia. But there are a couple other bacteria that occasionally come through, Haemophilus influenzae, Staphylococcus aureus being the commonest. Fortunately, gram-negative pneumonia is relatively rare. Atypical organisms cause a less aggressive disease, and those are the Mycoplasma and the Chlamydophila, and occasionally Legionella, which is an exception in that it can actually cause severe disease, despite being part of the atypical category of organisms. An important point is that many patients will have a mixed infection. So they have a viral infection that allows the bacteria in, so they have a combination of influenza A and, say, a pneumococcal pneumonia. And the same thing happens with Mycoplasma and Chlamydophila, that allows the bacteria in to cause an infection. So you get a combination of an atypical organism plus Haemophilus, Staph aureus, or Streptococcus pneumoniae. A very important point here is that actually, when it comes to the treatment of pneumonia, we don't normally treat the viruses, the exception being influenza A, which we'll treat with the neuraminidase inhibitors, because there are no good antiviral agents for most of these viruses. But we do have to treat the bacteria. So it's a question of which antibiotics to use. I'll come back and discuss the antibiotics in a bit more detail in a subsequent slide. Now, we do tests to identify what the pathogen is causing the pneumonia is. We actually limit these tests in general to patients presenting with moderate or severe disease, so are in hospital and have a reasonably high risk of mortality, 15% or more. And in these patients, we'll do a blood and, if possible, a sputum culture, although many patients are unable to produce sputums for this. We might do a viral nasopharyngeal aspirate to look for viruses such as influenza A. And there are two urine antigen tests that are useful in patients presenting with pneumonia. One looks for pneumococcus and the other looks for Legionella. And so we may send those as well. And those both have about a sensitivity of about 70% for those bacterial pathogens. The serology test for viruses, Mycoplasma and Chlamydophila are actually not often particularly useful. And the reason why is that to actually get a positive result for serology, you need a matched sample when the patient's ill and 3 or 4 weeks later when they're recovering. So serology in general does not guide therapy because it's a post-disease diagnosis. The changes in serology only really tell you they've had that infection 3 or 4 weeks after they've got better. The last test I've put down here is the HIV test. Now that doesn't tell you the organism that's causing the disease, but it's an important microbial test because HIV is an important risk factor for community-acquired pneumonia. And patients with HIV will develop pneumococcal pneumonia at a much higher rate. Apparently, it's about 20 times the chance of non-HIV infected person. And that increase in the chance of getting pneumococcal pneumonia is unrelated to having a low CD4 count. So a pneumonia is an early marker of somebody with HIV infection before they've developed significant immune suppression according to the CD4 count. And therefore, an HIV test in any situation where HIV may be relatively prevalent, an HIV test would be useful. So, antibiotics. You need to kill the invading pathogen. As I discussed before, it's the bacteria that we're really targeting, and the one that we really need to kill is pneumococcus, with some consideration for Staph aureus, Haemophilus influenzae, if somebody's particularly unwell. So in general, we need to also to cover the atypical organisms, Mycoplasma and Chlamydophila. Now the problem here is that the antibiotic that kills pneumococcus doesn't kill Chlamydophila and Mycoplasma necessarily. So the best antibiotic to use against pneumococcus is a penicillin such as amoxicillin. But that does not have any efficacy against Chlamydophila or Mycoplasma. For those, we need a macrolide. So if somebody presents with mild disease, actually, we've got a little bit of room to maneuver. If the patient doesn't get better with one antibiotic, then we can swap to another. So in general, what we do in those situations is that we'll treat them with amoxicillin or clarithromycin and see how they go. And if they're not improving, then we'd actually need to think about swapping. And the normal situation there is that somebody will receive amoxicillin, but it turns out to be a mycoplasma infection. And the amoxicillin, as it doesn't kill mycoplasma, the amoxicillin has no effect, and therefore we swap to clarithromycin. Moderate disease, because the patient's in hospital, because the mortality is now reaching 15% or thereabouts in the Curve 65 score of 2 or more, that's the definition of moderate disease, we'd like to make sure that we kill all the most likely pathogens. So amoxicillin is combined with a macrolide such as clarithromycin, so that we cover both the pneumococcus and the mycoplasma and the chlamydophila in those circumstances. Severe disease, when patients are considered for intensive care and have really quite marked systemic upset and maybe and have a high risk of death, then we just need to be a little bit more careful, and we extend the cover of the amoxicillin to co-amoxiclav. And the reason why we do that is that co-amoxiclav, Augmentin is its trade name, has better activity against Staphylococcus aureus and some of the gram-negative bacteria that potentially could be causing infection in these circumstances. And because the patient's terribly ill, we don't have much room for maneuver. We don't have much chance of making a mistake here and then correcting it later on. So the cover for potential pathogens needs to be extended accordingly. So in these circumstances, it's a combination of co-amoxiclav and a macrolide such as clarithromycin. An important point here is that some of the unusual gram-negative pathogens that are very rarely found in community acquired pneumonia, such as Pseudomonas aeruginosa, are not covered by these treatments. And that needs to be thought about if the patient's not getting better. Right, how do we monitor progression of the progress of the disease? Well, normally, patients with community acquired pneumonia presenting to hospital, coming in, receiving their antibiotics, their IV rehydration, they actually get better within a couple of days, for 2 to 3 days. Normally, the pyrexia will go away within 72 hours. Their pulse rate and their blood pressure will come back down to normal. And the oxygenation will improve. And as well, we can do a blood test to see where there's an improvement in whatever parameters that have been abnormal on the initial presentation. So, for example, the C-reactive protein, the inflammatory marker, which is normally quite high on presentation, should usually fall by 50% every 24 hours or so once the stimulation of inflammation has gone. So once the infecting organisms have been killed by your antibiotics, then the CRP will fall by 50% every day or so. So by the day 3 or 4, we'd expect the emitting CRP level to have fallen by over 50%. And things like the hyponatremia, the abnormal liver function test, the high white cell count, the high urea and creatinine, they should all normalize over the first couple of days of admission. If somebody's not getting better, if the blood tests are persistingly abnormal, if they're still hypoxic and there's still a pyrexia, you need to think about various things. One is that you need a chest x-ray to look for the complications. And if there's a pleural effusion present, then you need to tap that pleural effusion to make sure it's not infected. You need to think about reculturing to see whether the bacteria that is present might be a resistant organism. And I've mentioned Pseudomonas already as one of the organisms, the key organisms we need to consider. And then we just have to think about the diagnosis. Was this the right diagnosis? Did they have pneumonia? Or do they have one of those other conditions that I mentioned earlier? Is this a pulmonary embolus, for example? Is there pulmonary edema complicating this? Is there a cancer that makes the consolidation difficult to treat, as there's no drainage of that area of the lung? Or is this an inflammatory lung disease, which is not infective at all, a cryptogenic organized pneumonia, etc., etc.? The other issues that you can get with pneumonia are the complications. So we've mentioned severe hypoxia, we've mentioned septic shock, and I've also mentioned ARDS. And these are all physiological complications that occur with severe pneumonia. In addition, you have renal impairment. Again, I have discussed that already. But there are other complications. Patients in hospital are at risk of a deep vein thrombosis, so they might develop a deep vein thrombosis. Atrial fibrillation is a common complication of acute pneumonia, and that will settle as the patient gets better. Another important thing is acute cardiac ischemia. And that occurs in patients who are being stressed. And pneumonia is a great physiological stress for the body. And therefore, if somebody has underlying ischemic heart disease, then that could precipitate a myocardial infarction or angina or a decompensation if they've got cardiac ventricular impairment. So the important complications of pneumonia not to miss are infective ones, and this largely comes down to pleural effusions. Parapneumonic effusions, these are small effusions that occur in patients with pneumonia and are not infected, are present in about a third of patients, and these will resolve as the patient gets better. However, in a minority of patients, about 7%, 5 or 10%, that infusion will become infected and become a complex parapneumonic effusion, and eventually that moves on to forming an empyema. So this X-ray shows somebody presented with a left lower lobe pneumonia, but now you can see that the C-reactive protein was very high on the day of admission, about 330. 7 days later after treatment it got better, but then a couple of days later they redeveloped a fever, and the CRP has jumped back up to over 140. And the chest X-ray here shows some left-sided shadowing, the pneumonia, but also you can see there's some pleural shadowing going up the left-hand side of the chest. And this reflects an infected pleural effusion. And you can see that on the chest X-ray, and that is that diagnosis would be empyema in these situations, a complication of community-acquired pneumonia. Other infected complications are actually pretty rare, but you can get lung abscesses, and these are more likely in alcoholics or those who've aspirated, and is actually more likely with certain bacteria, Staphylococcus aureus, Klebsiella, and anaerobes. You can also get spread of infection from the lung to other parts of the body. This is pretty rare, but occasionally you get peritonitis, and infective arthritis, endocarditis as a complication of pneumonia. What is actually quite common in somebody who's been in hospital and treated for pneumonia, and the infections initially got better, then has deteriorated with an increasing fever again, is that they may have a line-associated cellulitis. So initial antibiotics given in pneumonia will be intravenous, and where the intravenous cannula has been placed, there's actually a relatively high chance that they can develop a cellulitis during their hospital stay. An antibiotic therapy can cause Clostridia difficile diarrhea, a superinfection of the gut with Clostridia difficile, and that is actually quite a common complication of patients receiving antibiotics in hospital and can be quite dangerous. Right, so that's a discussion about community-acquired pneumonia, which is the commonest form of pneumonia and the one that most people will be dealing with most of the time. There are, as I've mentioned earlier, other types of pneumonia, the hospital-acquired, ventilator-acquired, and there's the immunosuppressed pneumonia. And the reason why we define these as separate to community-acquired pneumonia is that the infecting organisms are going to be different. The chance of having a standard normal community-acquired organism is much lower in hospital-acquired disease. So, for example, hospital-acquired pneumonia, the common organisms causing disease in those circumstances would be Staphylococcus aureus and the gram-negative bacteria, Klebsiella, E. coli, Serratia, and Pseudomonas aeruginosa. And these organisms are harder to treat and do not respond to the standard amoxicillin and macrolide therapy that you use for community-acquired pneumonia. So they require very specific treatments. Immunosuppressed patients, because of that effect of having a very weak immune system, suddenly the patient is actually exposed to infection with a whole range of microorganisms that don't normally affect people. And that doesn't just include bacteria. The bacteria will be the same as you might get in a hospital-acquired disease, but in addition, there are a range of viruses, cytomegaloviruses, which may cause infection in these circumstances and cause severe disease. And in addition, the respiratory viruses that in most people are self-limiting and very mild disease, parainfluenza, adenovirus, etc., rhinovirus, cause much more severe disease in the immunosuppressed patient. And in addition, there's a range of organisms, fungi, which you may get infected with if you're immunosuppressed, which would never normally infect somebody who's got a normal immune system. And that's mainly Aspergillus and Pneumocystis jirovecii. So, hospital-acquired pneumonia is important because actually it is the commonest fatal hospital-acquired infection. So you need to know about this as a disease that requires close attention and aggressive treatment when it develops. The treatment needs to cover the organisms that we discussed, Staphylococcus aureus, the gram-negatives, and Pseudomonas. And therefore, patients will normally be receiving coamoxiclav, ciprofloxacin, third generation cephalosporins such as ceftazidime. They need a more extensive antibiotic regimen that you would normally use for community-acquired pneumonia. The actual presentation of hospital-acquired pneumonia is pretty much the same as community-acquired pneumonia. Cough, fever, shortness of breath, and with new consolidation and a rise in the markers of inflammation. Pneumonia in immunocompromised hosts is very much more complex than normal pneumonia because of this extended range of organisms that may be causing the problems. And again, just to reiterate, we're talking about patients who have really quite marked immunosuppression. They have to have an organ or a bone marrow transplantation. They've been receiving chemotherapy or high-dose cytotoxic agents or biological agents to immunosuppress them because of a major inflammatory disease such as connective tissue disease. Or they are HIV infection with a low CD4 count. Or they have a hematological malignancy, which by their very nature affect the white cells and therefore make you much more immunosuppressed than you would be normally. And the situation here is that there's such a large range of organisms that the decision about treatment options is much more complex than it would be in a normal person presenting with community-acquired pneumonia. Because you may need to treat respiratory viruses, you may need to treat cytomegalovirus, you need to treat for the organisms that may cause hospital-acquired pneumonia, and then there are the fungi, Aspergillus and Pneumocystis, and unfortunately Aspergillus and Pneumocystis require very different treatments. So it's a very complex situation that requires clinical assessment to make sure the right medication is given to the patient. And often these patients will end up on antibacterials, antivirals, and antifungal agents because we're not quite sure what's going on. This is a CT scan showing what an invasive fungal infection looks like after a stem cell transplant with focal disease at the top of the left lung.